Hello everybody, I'm Raphael Gazzotti and I will present you the work we did with my supervisor, Catherine Faron-Zucker and Fabien Grandon, and with the physician Virginie Lacroix and David Darmon about the injection of automatically selected DBpedia subjects in electronic medical records to boost hospitalization prediction. This work is a follow-up of the paper we published at SWC, where we evaluated the impact of different knowledge graphs. So, in order to introduce you with some background, in France we have a rate of 191 hospitalization per 1,000 inhabitants, and 90% of the population problem are managed by general practitioner, and full hospitalization lasts around 6 days. For full hospitalization, and for the most common health issue. It is therefore, for the society and for the well-being of the patient, an issue. The general practitioner are the cornerstone of the healthcare system, and it is perceived for them as a failure to send their patient to the hospital, because this is the last resort they have, and that doesn't mean to improve the health condition of their patients. And it is difficult for them to know what is the problem to handle as a priority, because most of their patients are in the states of comorbidity, a multiplicity of chronic diseases. So we use the pre-merge datasets. The pre-merge dataset was constituted since the beginning of 2012, and these projects aim to collect data directly from the general practitioner consultation software. And here in the bottom you have an example of what you can find in the pre-merge database. With the translation reason of consultation, you have the tetanus vaccination. For the history, appendicitis. And for the observation, here in French you have some abbreviation, so that can be a bit difficult to read. In first grade, good general condition, clear pulmonary auscultation, regular health sounds without breathing, abdomen okay. And in this database you have a lot of medical information, like the past medical history of the patient, the history of his family, drug use, and international codes. And these projects aim to be generalized across all the fronts, because right now it was implemented in the PACA region. We used for experimentation a sample of this dataset with 714 hospitalized patients and 732 not hospitalized patients. So we define different research questions, with the main research question with how to extract knowledge relevant for the prediction of the occurrence of an event, and we will see the different sub-research questions during this talk. For the textual representation we use a bag of word representation that allow us to extract the main information without requiring a large corpus. The different attributes are not transformed, and that allow us to integrate heterogeneous data by the concatenation. And so we concatenate another vector, concept vector, where we extracted concepts from the different text field in this work. And so we use for both the occurrence, one for the occurrence of term, and for the other one the occurrence of concepts. We use different algorithms that allow us to have a native interpretation of their decision, and we use different machine learning algorithms with the supervector machine with a linear kernel, the logistic regression, random forests, and the logistic regression and random forests are commonly used in the prediction and also in the classification in the medical sector. And so that was really important to have a native interpretation, to have an interpretation of the decision of these different algorithms, because for the general practitioner they need a reason for why a patient will be hospitalized. So they are able to know the different factors on which they can have an impact in order to prevent the hospitalization of their patients. and the limited size of datasets was not appropriate in order to use neural networks approaches. So because we have to handle the temporal dimension, and because we use a non-sequential algorithm, we had to aggregate all the different consultations of the different patients. So for the hospitalized patient, because we need to predict their future hospitalization, we use all the different consultation before the hospitalization of a patient. So we have a different pattern in the pre-image dataset where the return of hospitalization. And for the not hospitalized patient, we use all their consultation. So we go to the first research question on how to filter relevant domain knowledge from a general knowledge source. So here you have the pipeline in order to extract concepts. So we use medical records in French with the DBpedia Spotlights tool that allow us to extract named entities and link them to DBpedia. And also we use the symbolic approach in order to handle unambiguous abbreviation and acronyms. So on one hand, we did a constraint on the DBpedia French chapter, and also another one on the English chapter. So here we have the query we use. So for the French constraints, we did the constraint on the hierarchy of the different borders, and we selected the concepts who have as broader disease, health, medical genetics, medicine, urgency, treatment, anatomy, addiction, bacteria. And for the English chapter, we selected the concept the resources who has as type disease, bacteria, Wikicat viruses, Wikicat retroviruses, Wikicat surgical procedures, Wikicat surgical removal procedure. So with that, we can decrease the amount of concepts not relevant for the medical area. And here you have an example of what we can find out in the pre-image dataset with the consultation. With just text. So you have the English translation of French with abbreviation also. Predominates on the left, venous or cardiac insufficiency, no evidence of phlebitis, does not want to wear compression stocking, and does not want to increase the elastics. So with cardiac insufficiency, you can extract from DBpedia the concept cardiovascular disease and organ failure. And on the right, you have another example. So we arrive to our second research question with how to deal with subjectivity in the annotation process. So here you have the pipeline in order to a bigger pipeline in order to do our process in order to concatenate both the bow and the bag of concepts. So from the text we extract feature with the bag of words, and we run DBpedia Spotlight in order to retrieve concepts that allow us to construct a vector of concepts. And for the vector of concepts, we also use an automatic approach in order to proceed to the kind of annotation and to select the relevant concepts by an automatic way with a lasso cross validation only on the bag of word. So with that we can generate annotation with feature selection. And we also annotate the data by humans with, we extracted 285 subjects, and they are annotated by 2 general practitioners and 1 biologist. And the goal of the annotation was to annotate the data, to annotate the concepts if they are useful in order to study the hospitalization risk. And we had an entire agreement with the Krippendorf alpha of SAC2020 between the general practitioner is quite low, and we remove terminological conflict, because when we have an expression starting like a symptom of something, well, all the different concepts associated to that starting expression were annotated as relevant or not relevant by one of the annotators. We arrive to 0.52 between the GP, and at the average 200 concepts are annotated as useful by the different annotators. And on the right you have the form we propose to the human annotators. And also, in order to see the distance between the different vector of concepts, we use a correlation metric. And the correlation metric ranges from 0 to 2, 0 for perfect annotation, perfect correlation, 1 for no correlation, 2 for perfect negative correlation. And this metric is derived from the cosine distance. Here you have the table where we describe all the different correlation metric between all the different annotators. So from A1 to A3 you have the human annotators, and from M1 to M10 you have the best approaches with automatic selection. And so M1 is for the first fold and M10 for the last fold, because we use cross-validation with K10 fold. And U1 is the union of all the different concepts retrieved between M1 to M10. And so we had a maximum of 0.681 between the humans and 0.485 between the machines. And for the machines, U1 was similar to M5 with a score of 0.12. So we have a closer annotation between the machine than the humans. And so we arrive to our third research question. Sub-research question: is automatic extraction and selection of knowledge efficient in that context? And for the experimental protocol, we use nested cross-validation with a K at 10 for the outer loop and a L at 3 for the inner loop. And we set the hyperparameters with a random search of 150 iteration. And for the metric we used in order to compute a result was FCP-FP made by Foreman and Schultz, that is really suited in a cross-validation context. So basically, for the true positive, false positive, and false negative, we compute all the results. We do the sum of all the results across all the folds, and we use the formula within the bottom of this slide. And also, we test out another approach where we try to generalize the concepts selected by the machine annotators. Because for the machine annotators we have different concepts selected during each fold, well, M1 to M10, and so we build the intersection of the concepts retrieved by these different machine annotators, and also the union. And so for the results, the baseline uses only bow on all the data, and we add to that for alpha all the concepts all the concepts we get with the query we've seen before, so the 285 concepts, and the concepts are retrieved from the focus patient on record. Well, we use the focus on patient on record in order to get the concepts for the approach alpha to epsilon. Beta is the intersection of concepts estimated as relevant by the experts. and gamma concept unanimously estimated relevant by experts. Epsilon, that was the automatic approach, and zeta the automatic approach. And so for the baseline we have something around 0.84, and we get not great result for the alpha approach, where we had all the different concepts, and for beta and gamma get better result, but not that better, worse than the baseline. For epsilon, we have an increase because we have results of 0.86, and also that was better with zeta, where we used all the different text field with the feature. We use all the different text field in order to get the concept. So we have added concept retrieved from the family history of the patient, and we get also better results with union of the generalization of concept from the zeta approach with 87. And so the best results were achieved with machine annotation. And so for the concept retrieved with the zeta approach, we had a much smaller set of selected concepts, with 51 concepts selected. And so we had different kind of concept retrieve, with some really generic, some related to the patient mental state, some related to the infectious disease, some other related to cardiovascular system, and some other specific to the family. And so here something that can be seen is that medical terminology not selected by human experts as first can be seen as useful, because we can conclude that general practitioner use technical terminology in a situation involving a complex medical case, and also semi-supervised step allow to retrieve most relevant concepts, so that can be useful in order to help human annotators to select relevant concepts. So for our limits and future work, we want to couple semantic relationship and text data, and aiding new medical domain knowledge with the integration of annotators on other knowledge graph, and address the weakness of the approach we use with DBpedia, with a better management of abbreviation and spelling mistakes, use of different level of hierarchy, and detect the negation and the context of a medical concept, and identify complex medical expression. So, thank you for your attention. Bye bye.